So the influence of the gut microbiota on host metabolism through the regulation of gut hormone release. Published in 2019, this review aims to describe the complex interactions between intestinal microbiota and the metabolites and their metabolites and gut endocrine cells, and highlights how the gut microbiome can influence host metabolism through the regulation of gut hormone release. And in that paper, there are some really colorful diagrams, and I put this in here to remind myself to tell you that it's complicated. The biochemistry is complicated, but the interventions are not. This is often true with functional medicine. You know, you get like, tomorrow just bring your seatbelt because Bob Roundtree will be in the building. And he is going to completely explode your brain with biochemistry surrounding inflammation. And it's really complicated. I saw this beautiful lecture between him and another presenter, and complicated. Oh my God, I'm never gonna, how can I possibly do this? And then they said, yeah, but the treatment is really, I don't know, like maybe some fish oil. And that's really the truth. The interventions for this dysbiotic situation are maybe some more root vegetables, maybe some more prebiotic vegetables, maybe a probiotic short to intermediate term to kind of as placeholders, and some more pretty but complicated pictures, and all kinds of metabolic influences and networks. So it's much more rich science than just which bug is where. And we learned a little bit ago that butyrate is really important. And in this case, the butyrate is low. And what can I infer from a low butyrate? Probably, I can infer that there's insufficient prebiotics in this person's diet. Because butyrate is made from prebiotics, right? So butyrate, beneficial short-chain fatty acid derived from the fermentation of soluble fiber by anaerobic probiotic bacteria. And I'm betting that there's plenty of anaerobic probiotic bacteria in the gut. So it's probably the insufficient fiber, but it could be the other way around. But generally speaking, if you build it, they will come. If the food is there, the bug will find its way. So it's probably not that the bacteria isn't present, it's that the fiber isn't present. Primary metabolite for colonocytes within the lumen. So the, not hepatocytes, because it's not the liver, but the enterocytes use butyrate as a primary fuel. It prevents and treats colonic inflammation, and it's low in dysbiosis and or low fiber. And I just told you it's generally speaking low fiber. So here is a culture that we already saw. And so what does this mean to us, and how are we going to try to treat it? Well, we'll treat it, if there's sort of two pieces. Is there a pathogen or a potential pathogen present? Is it normal or excessive? And then there's our beneficial bacteria. Are they normal or excessive? So if we have normal pathogenic load and normal beneficial bacteria, we're probably not going to treat that. On the other hand, if you have normal beneficial bacteria but an excess load of potential nasty things, we're going to consider some prebiotics and probably some probiotics and maybe consider some antibiotics. If you have a deficiency of beneficial bacteria but no evidence of pathogenic bacteria, so we're going to think about, well, we're going to treat this person gently because there's no pathogen involved. So we're going to treat them gently. We're going to treat them with some prebiotics, some probiotics, and dietary change. But what if you have both? That's a full meal deal. We're going to do what needs to be done. So we're going to use prebiotics, probiotics, consider antimicrobials. So what would be a diet change? We want to increase prebiotic foods. We want to increase fermented foods. So kimchi, sauerkraut, specific carbohydrates. So again, appropriate prebiotics, soluble fiber, which promotes short-chain fatty acid production. And then what kind of dosing? We'll talk about dosing. There are 3 things necessary to be considered a prebiotic. It needs to be non-digestible by the human. It must be fermentable in the GI tract by endogenous anaerobic colonic bacteria, and it must be selective in stimulation of the intestinal flora metabolic activity. And, you know, everybody talks about healthy diets that are so terrible. It's really awful when you have to have onion and ginger and, you know, these kinds of foods. You know, it's really terrible. So gut central nervous system axis is a target for nutritional therapy. Recently, it was observed that a prebiotic-enriched diet reduced firmicutes and increased Bacteroides levels, as well as improved glucose sensitivity, body fat, inflammation, and oxidative stress. I'm wondering which drug could do that. So what about prebiotics? What is a sick gut? A sick gut has elevated inflammation, elevated bacterial translocation, meaning that the bacteria actually migrate across the mucosa. Intestinal permeability, increased firmicutes, decreased Bacteroides, decreased insulin sensitivity. A healthy gut has all the opposite attributes. So in the United States, there are just a few sort of supplemental prebiotics. Other places have more of them. And prebiotics are going to stimulate some bacteria, so you might imagine there's some side effects. Here's some prebiotic foods. So practical issues. Treatment timeline. They say here indefinite. I disagree with that. I should say this. Our thinking has evolved. So I don't think it's indefinite. It's until the lifestyle factors have changed in such a way that the prebiotics are just part of the diet, right? And then, so fructose oligosaccharide is going to be 1 to 5,000 grams, or excuse me, 1 to 5 grams daily up to TID. Inulin is up to 5 grams TID. And then, highly soluble fiber like larch or modified citrus pectin, again, somewhere in the 5 grams once to 3 times a day range. Gut central nervous system axis, again, is a target. Prebiotics are defined as living organisms that can be administered in adequate amounts, confer a health benefit. That's the World Health Organization definition. And can probiotics affect intestinal permeability? Probiotics positively affect the host by enhancing the microbial balance and therefore restoring normal intestinal permeability and gut ecology. In clinical trials, probiotics appear to be useful for the treatment of a variety of clinical conditions such as food allergy, atopic dermatitis, and allergic rhinitis, not to mention some GI issues. So can probiotics affect depression? Now, I am kind of a Carl Sagan kind of dosing guy. You know, Carl Sagan is the guy who used to say billions and billions of stars. And I'm kind of a billions and billions kind of probiotic user. And in this study, 24 billion colony-forming units, which I consider to be kind of like spitting in the ocean, when you think that there are actually trillions of bacteria in the gut. 24 billion colony-forming units of lactobacillus were shown to improve the Beck depression and Beck anxiety scores in individuals. So yes, they can indeed affect, and there are many other studies in this realm, they can indeed affect depression. And then prebiotics, you know, we've looked at this. The gut microbiota shapes the intestinal immune response during health and disease. It has recently been proposed that the total information encoded by the mammalian genome is insufficient to carry all functions that are required to maintain health, and that products of the microbiome are crucial for protection from various illnesses, diseases. If some bacteria are actively shaping a healthy immune system, does the absence of these organisms lead to disease? And in the view of IFM and functional medicine, that's an easy yes. So epithelial cells, recognition of commensal bacteria, and maintenance of immune homeostasis in the gut. So longitudinal analysis of the diversity of commensal bacteria in newborns suggests that there is no deterministic or stereotypic pattern of acquisition. Instead, commensal bacteria appear to be acquired really as opportunistic colonization based on their environment. Maybe it was Joan who changed from breastfeeding to formula feeding. That's a fundamental change in your diet, and it changes your microbiome. If you're a C-section as opposed to a vaginal delivery, that's a completely different bacterial exposure. In fact, your first bacterial exposure in a cesarean section is actually that of the surgeon as opposed to the mother, and that's a frightening thought. So microbiomes and development of gastrointestinal tract. Newborns fed with formula, so I talked about this, have predominantly Bacteroides, whereas with some bifidobacteria, whereas breastfed babies are predominantly colonized by bifidobacterium. Mesalazine, can't even say that word, versus lactobacillus in prevention recurrence of symptomatic, uncomplicated diverticular disease in the colon. So these are people who are stable with regard to their diverticulitis, and they're given either mesalazine as a prevention, lactobacillus as a prevention, or both. It appears that lactobacillus was as efficacious as mesalazine, and when they gave both, it was 100% effective at preventing recurrence at 12 months. In ulcerative colitis, this is a very large dose, 3.6 trillion bacteria per day. And you can see here that a little north of 50% of these people went into remission. Another 20%, north of 20%, had a response of some kind. No response was a little shy of 10%, and then worsening was shy of 10%. So the vast majority of these patients got better on a probiotic. So what's the mechanism? There's lots of mechanisms. I think it's easier to see on this slide. So we can decrease the luminal pH. There are bacterial-derived proteins which resist colonization. We have decreased epithelial binding of pathogens, decreased epithelial invasion, increased beta defensins. It improves epithelial function through the production of short-chain fatty acids, through mucus production, through optimizing apoptosis, by improving the barrier integrity, by producing that 30-micron thick biofilm, and increases some heat shock protein issues. And then it improves immune regulation through all these mechanisms as well. So there's quite a lot going on. And then there's a vast, intricate, and unexpected level of interdependence between beneficial bacteria and the immune system. These results support the hypothesis that an imbalance in the intestinal microbiome is influencing the development of lifestyle-related disorders such as allergy. And so here are some proposed uses, and you see that these uses are across systems, not just gastrointestinal, but UTIs and atopic disease and systemic inflammation and dental disease and radiation-induced diarrhea and so on, even rheumatological diseases. And here are some dosings. So, lactobacillus, someplace in the several billion colony-forming units per day. Saccharomyces is measured in milligrams. If I have a really bad case, I'm going to use 1,000 milligrams twice a day, but generally it's 500 once or twice a day. Bifidobacterium, similar to the lactobacillus. And then mixed probiotics, into the trillions per day. Prebiotics, we already went through some of these dosings. So, changing the microbiome is hard. Changing the microbiome is hard. To date, only stool transplantation and changes in the diet can really make permanent change. So, at one time I was planning on starting a chain of hospitals, stool hospitals, international for transplantation. I'll let you work out the initials there. And, but what happened is the FDA said that you really can only use stool transplantation for C. diff. If you use it for things other than C. diff, it's a new drug and you need a new drug application. So that kind of put a halt on that idea. But prebiotics or probiotics should be thought of placeholders rather than really effective treatment. And what we do is we use prebiotics until we get we use probiotics until we get the prebiotics on board, and then ultimately get the diet and lifestyle changed in a more permanent fashion, and then we can start to withdraw some of the prebiotics and probiotics. So what about Joan? And what should we be thinking about with Joan? So, you know, we've got the dietary changes, the prebiotics, the probiotics. So, you know, we've already got to this point where we've done our elimination diet. We're thinking about our antimicrobials. We've given her pancreatic enzymes. We are thinking certainly about prebiotics and probiotics. And then what does she need to repair her gut lining? So, we notice that her secretory immune globulin A is low. So it's the primary immune globulin in mucosal secretions. It's found in tears, saliva, sweat. It's found in colostrum. It's found in secretions of the GU, GI, and respiratory tracts. It can inhibit the inflammatory effects of other immune globulins. So a low immune globulin A is actually a pro-inflammatory condition. It's a good activator of the complement system, and it suggests immune activation if it's elevated. So, do we want to include some kind of a strategy to increase secretory immune globulin A? Well, let's see about GI immune enhancement. Whey proteins with concentrated immune globulins, Saccharomyces, glutamine, and larch are all candidates. And then from a 5R perspective, what should we be thinking about with Joan? So consider some kind of medical food. This is going to make you crazy all week. We're going to talk about medical foods, and these are just convenient ways to mix a whole bunch of nutrients that are beneficial. Immune support for the decreased immune globulins. So I want to talk now about this foundational anti-inflammatory protocol. Certainly the elimination diet, prebiotics, vitamin D, omega-3 fatty acids, and glutamine. So we've seen this slide already and the whole issue with inflammation. The elimination diet, Dr. Bischoff is going to talk about tomorrow. And then biofilms and inflammation. And we've talked already about this 30-micron biofilm. So, you know, on the internet right now, it's biofilms are bad. You've got to eliminate biofilms. We've got to have some biofilm busters. Well, that makes no more sense than trying to sterilize your gut. So instead of thinking about killing every last living organism, we want to selectively harvest, right? So we want to shift that biofilm from a dysbiotic biofilm to a probiotic biofilm. And we can do that by using some of the strategies we already discussed, these immune globulin strategies, these prebiotic strategies, things like that. And then what about vitamin D? Vitamin D downregulates nuclear factor kappa B, or NF-kappa B. It increases IL-10, decreases IL-6, IL-12, all of these fun things. And it leads to a cytokine profile that favors less inflammation. So vitamin D should be a part of our anti-inflammatory practice. Vitamin D is also one of the things necessary to improve intestinal permeability. When zonulin says open the gates, vitamin D helps close the gates. Vitamin D deficiency may compromise the mucosal barrier, leading to increased susceptibility to mucosal damage and increased risk of IBD. 230 inflammatory genes were downregulated, 298 anti-inflammatory genes were upregulated in the colon by vitamin D in mice. So what's a protocol for vitamin D? How about weight-based dosing? In Minnesota, where in the wintertime there aren't enough photons to actually make vitamin D, and in the summertime there are too many bugs to be uncovered, you need about 5,000 units a day to get sufficiency, someplace above 40 micrograms per deciliter. And other places vary, but if you happen to live, people say, yeah, but I'm from Arizona. Okay, well, you go from your air-conditioned house to your air-conditioned car to your air-conditioned building, and you wear shorts and you get tan from here to there, and maybe you wear short-sleeve shirts and maybe shorts and you get tan from there to there. But if you look at a burn diagram, that's not that big of a percentage of your body, right? So you still need supplementation, and my experience is you still need a couple of thousand units. So recheck in 8 weeks. And, people come in all the time on supplements and whatever, and we measure their vitamin D at less than 12, less than 20, less than whatever, all the time. So you really need to look at this at least once, and probably 2 or 3 times to get it sufficient. So we talked about vitamin D. What about the omega-3 fatty acids? Reduce pain and inflammation naturally, part 2. New insights into fatty acid supplementation and its effect on eicosanoid production and genetic expression. Fish oil appears to exert much of its anti-inflammatory benefits by suppressing NF-kappa B via PPAR-alpha. Endoscopic endpoints were used to evaluate the role of fish oil in the treatment of ulcerative colitis. 3 of 3 studies showed statistically significant improvement in the study group that received fish oil supplementation. The safety of fish oil supplementation is high and has been well established in numerous clinical studies. Drug interactions are extremely rare. Doses of up to 3 grams of EPA plus DHA have been determined to be safe for the general population. Now that's sort of my starting dose for an anti-inflammatory dose is 3 grams. I tell people, look at your bottle, it'll say something like fish oil, 1 gram. I don't care about that. You turn it around on the back and you read, how many pills does it take to get 3,000 milligrams of EPA plus DHA? That's your starting anti-inflammatory dose. And I sometimes go up. I think it's very safe, but if you go a lot higher than this, you do need to be concerned about maybe bleeding and so on, but I think that's actually pretty rare. So here is some dosing guidelines for EPA and DHA, total omega-3s. Dosing up to 20 grams a day. So we've talked about some omega-3. What about glutamine? It's a preferred fuel for enterocytes of the small intestine. It increases intestinal villus weight. It stimulates gut mucosal cellular proliferation, maintains mucosal integrity, prevents intestinal hyperpermeability and bacterial translocation. Gastrointestinal tract is by far the greatest user of glutamine in the body, as enterocytes in the intestinal epithelium use it for their principal metabolic fuel. And TPN, total parenteral nutrition, that has been enriched with glutamine has been shown to decrease villus atrophy, increase jejunal weight, and decrease intestinal permeability. And clinical studies on ulcerative colitis patients, 30 grams a day of glutamine for 4 weeks. There was a significant improvement in endoscopic endpoints, and disease exacerbation returned when the treatment was discontinued because this was a single nutrient intervention. If you do this as part of a 5R program, you're more likely to get lasting results. So what do we think? Well, a couple of grams. The stuff I use is like 4 grams per scoop or thereabouts, and I generally start with 1 or 2 scoops a day, and I go up from there up to around 40 grams a day. Some people have a hard time tolerating that much, but often not. So we've got this much of our protocol kind of built at this point. And what next? What does this patient need to have rebalanced? This is the hard one. What does this patient determine the need for rebalance? Well, let's look at this for a minute. And then let's look at this. And we've got parents divorced and the trauma, the echoes of that trauma. We've got the diagnosis of lactose intolerance. We've got 2 kids who are now 27 and 29 with her history of postpartum depression. We've got her current depressive state. We've got the stressful job and family dynamics with her ex-husband. We've got the seasonal affective disorder and the inflammatory diet, that SAD diet. We've got poor sleep and relaxation habits. We've got essentially no movement in her life. We've got nutritional elements that need to be addressed. We've got her kid issues and all these things. And then her relationships. The boys are a handful, and she doesn't have any kind of friendships and no intimate relationship. So she's pretty isolated. So we need to think about modifying this. And, it's one thing to say, yeah, you should fix your diet. It's entirely another thing to help people do it. So we need to create programs for these people. We need to create community around how to do this. And so part of what we're going to do is try to find she's likable, so she's got friends at work. So we're going to try to recruit one of her friends at work to maybe walk with her at lunch and to maybe take turns making lunch for each other, so it's a little bit less of a burden on one day, but maybe not that much bigger of a burden on the next day, and it'll be an accountability partner. So if I don't do it, my partner doesn't get lunch, and if I bring, ding-dongs and ho-hos, my partner is going to be a little bit upset with me. So there's some accountability there. Plus, it's just fun to be fed, right? So it's fun to feed, it's fun to be fed, and so we'll create some kind of community here surrounding how to do this. So this rebalancing, we got to create this program. We've got the prescription, antimicrobials, we've got all of these pieces that we've built into here, and now we're talking about rebalance. And now from rebalance, this is the thing that prevents relapse. Without rebalance, she will relapse. And you will be just another practitioner along this long road that wasn't able to really help her. Rebalance is the most important thing. And so this requires thinking, because she's overwhelmed and she's ill and she doesn't know how to do it. But she's motivated now, because you've done a lot of these things. This is happening over iterative, successive visits, and she's getting better over time, and now she's motivated, and she sees the issues in her face that are causing this disease, and she will be very motivated to do it, but she doesn't know what to do. So this is where a coach is very helpful. This is where somebody who can have recurrent conversations with her and help her brainstorm how can she build community around this healthier lifestyle, like the friend at work kind of idea, or like some kind of, because the truth is everybody she knows is in this same boat, right? What if she starts some kind of a deal where people get together on someday, a Sunday afternoon, and they make a week's worth of meals for the whole group. And guess what? That turns into fun by accident. And it becomes community. So thinking outside the box. I don't really even like that term. I don't want to think outside my box. I want to make my box a whole bunch bigger. Just make the box bigger. And then we have to track. So it's not enough to just do these things. Now we have to track. We have to see every intervention. Did it make her better? Did it make her worse? Was she the same? And if she's worse or the same, we're probably going to have to change something. But if she's better, we're going to follow that path until it's not serving us anymore, and then we're going to change something. So track. So now what I want to do is I want to go back to that original discussion with an entire day of thinking about it now. So this morning I asked the question, is it really possible to treat somebody without treating their disease? What an irrational question. But now I want to think, is it really possible to treat? Do I treat disease? Are we really treating disease? I treat people and their unique relationship to the world. To a large extent, functional medicine is independent of the diagnosis. This is such a pivotal, important concept. I want to talk about that again. And I want you to really develop some stories. I want you to tell each other stories about how that's true, how you've seen that to be true, or how you can see that to be true, and kind of develop your elevator speech, as they say in sales presentations. What's your elevator speech about how you treat things in functional medicine? That's an important piece of this that gives you some confidence on Monday morning when you get home. So what are the obstacles to applying this information in clinical practice? So we have forms. We have a toolkit. Use the tools. You don't have to reinvent the wheel. Find mentors. The Functional Medicine Forum, or whatever it's called these days, is a great place to present cases and get feedback. Continue to do the functional medicine modules. Here's our favorite guy. It's a wonderful feeling to recognize the unity of complex phenomena that, to direct observation, appear to be quite separate things. So, keep an open mind, just not quite so open that your brain falls out. And unless there's a compelling reason to do otherwise, treat the gut. Remember that the gut is this complex web, this node within the complex web, which is human physiology. Remember, dig in. Remember 5R. Remember that to a large extent the microbe is nothing, the terrain is everything. If you think you're too small to make a difference, try sleeping in a room with a mosquito.